Good afternoon, everyone, and thank you for attending today's webinar, Patient-Centered Medical Homes. What are they and why should I care? Presented by Jennifer Tierney of JLS Advisory Group, LLC. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar. Again, NJMGMA would like to thank you for attending, and I will now turn things over to Jennifer.
I'd like to start by saying thank you for joining this presentation today. Today, I wanted to introduce myself. My name is Jennifer Tierney. I'm the founder of JLS Advisory Group. My experience prior to consulting was primarily in the health plan arena. And one of the things that I've noticed as healthcare industry has changed over a period of time is that some of the concepts where insurers had things like quality improvement using data are now being pushed down to the provider level. And it's part of the reason why I'm very interested in the patient-centered medical home model. My certifications include NCQA, Patient-Centered Medical Home Certified Content Expert. As that, I'm required to take a written exam which tests the knowledge and requirements, the application process, and documentation that NCQA requires to become a PCMH, or some of the other programs that I'll cover later today in the presentation. In addition, there's also continuing education that is required, and it's 30 hours every 2 years, so there's a fair amount of continuing education. And what my business is about is really simplifying the business side of healthcare and improving outcomes. This allows providers to focus much more on patient care rather than some of the administrative aspects of their business. So next, we're going to move into the actual presentation. Today's topics, we're going to talk about what the patient-centered medical home model is, a little bit about its background and how it's been developed, learn about options to be independently certified as either primary, specialty care, and/or urgent care. There's also an option under NCQA for workplace and retail clinics. Gain knowledge about what the independent certification process actually entails. So I'm going to go into a little bit about how NCQA operates, because that has well-defined criteria and actually has been more popular than some of the other accreditation models out there. And then lastly, I'm going to talk about some of the reasons why your practice can benefit and why it's important to insurance companies and ACOs for you to go ahead and achieve PCMH recognition. And following that, we're going to have a question and answer session. So what is the patient-centered medical home? The medical home actually was developed originally back in 1967 by the American Academy of Pediatrics. It was designed to focus on having a central location for children's medical records, and since then, over a period of time, it's evolved. In 2007 was probably the area where things started to change the most. The Institute of Healthcare Improvement issued a statement about the triple aim. The triple aim is focused on improving patient health, improving the patient experience, and looking at controlling per capita cost for insurance, cost of what healthcare is growing. As everybody knows, the cost of healthcare has escalated, and it's really not supportable in the current model. Also at the same time, in 2007, the Joint Principles of Patient-Centered Medical Home were issued, and it was a collaboration of multiple primary care physician societies, and those are listed on your slide. It includes the American College of Physicians, the American Academy of Family Physicians, the American Academy of Pediatrics, and the American Osteopathic Association. So all of these came out, and that's almost 333,000 physicians, and the Joint Principles described what was being proposed as the patient-centered medical home model. So some of these joint principles include the characteristics. It is talking about everybody having a personal physician. So one of the key aspects is to actually be able to select who you're seeing, which has been a bit of a change at sometimes, particularly in pediatric practices, often a person sees whoever's working that day, if it's for a sick appointment as opposed to a well appointment. And some of that is to go ahead and change that so that you have a relationship and you're able to build a relationship with your physician. Also, the concept of team-based medical practice with physician actually directing care has become a component as well. Some of the other aspects are looking at the whole person, not just looking at the need that the person brings into the office that day, but looking much more preventatively and at the whole person. What are the different aspects of care that they need? Coordination and integration of care is really talking about making sure that if the primary care office can't support all the needs of the patient, that it is coordinated amongst other specialties. And you'll hear talk about the medical neighborhood, which can include not only specialists, but it also includes hospital, it includes community support, it includes a variety of supports that the person engages in managing their health and care. There's a focus on quality and safety, which is related to one of the reasons for getting accreditation is a commitment to quality. Enhancing access, which just means that the office hours are more available and you can readily get information. Pretty much in today's society of 24/7, people want to have access to information around the clock. And also, a key component, which I think is still being dealt with in the industry and hasn't fully come up to where it needs to be, is that the payment to primary care in particular recognizes the added value of all these principles of a patient-centered medical home. And while some aspects of this are already in place, really the focus is to look at the patient's health as a plan of care. So looking at it prospectively and doing it on a more proactive basis, as opposed to when a person comes in and they have a problem today and focusing on that problem of today's issue as opposed to what it means in the bigger picture of the person's health. Also, a patient shouldn't have to coordinate their care directly. They're involved and engaged in the process, but to have the professional team involved in helping coordinate that care. There's also an emphasis on evidence-based guidelines and making sure that when there are tests and different consults that there's follow-up by the primary care and to make sure that that is being addressed. So primary care, some of this I already talked about. Relationship-based, and these are again characteristics patient-centered. It's relation-based, it's dealing with the person as a whole. Comprehensive, that the primary care is really looking at what is going on in the person's life across the spectrum of their healthcare needs, and that they're using a team to do that. Coordinated, I've already talked a little bit about the medical neighborhood. Accessible, again, shorter wait times, having access. You hear a lot about open access, making sure that people can get in for an appointment. And I think that in most cases, a lot of this has already changed, which makes it easier to get in to see a doctor. I can remember several years ago when you would have to wait 2 weeks to get an appointment, and if you were sick and you had to wait 2 weeks, chances are that either you've gotten better or that appointment time is no longer necessary, and that has changed as well. Quality and safety. CQI is continuous quality improvement. Continuous quality improvement is really a mindset that should be adopted within the practice when you're looking at patient-centered medical homes. The idea is to constantly look at what your results are, evaluate whether or not they were effective, and then make changes. And so it's a continuous cycle that never stops. So as you try to make interventions and see if they worked great, how do you continue it? If they didn't work, what do you go through and tweak to make changes? And this is one of the concepts that I know the health plan sometimes can be the dark side for those that are out in practices, but it's one of the things that is actually very embedded into insurance companies, which is part of the reason, like I said, I'm very interested in this, because it's pushing it to the front lines. And really, to get patient engagement, it has to be at the front of the line where the doctor or the physician, the nurse practitioner is involved with the patient. It can't really happen at insurance company level because they're too far removed. The other parts that relate to quality and safety are also the clinical support tools. What do you have built into your EHR? Looking at your population. So who are the patients that you see? What are the types of needs that they have? And satisfaction is the last aspect, which is evaluating patient satisfaction with the services that are being delivered. So it entails reviewing aspects of all levels of engagement, whether it's the front desk, whether it is the actual medical team, or if it's follow-up care. So really looking at satisfaction from all aspects. And the other key point is that it's for all stages and ages of life. It's not just focused on just the acute care, but it's looking at preventive, it's looking at chronic, it's looking at behavioral. So all of these are characteristics of what primary care services should entail under a patient-centered medical home. And then the next slide, we're going to talk a little bit about the goals. So what happens after you've implemented all of this? So the idea is to really treat the person as a whole, making sure that they're having a good experience in the office. And I think I'm not going to read everything to everybody on slides because I hate when people do that in presentations. The other big change is to look at a patient and really engage that person, which is probably the hardest component of making sure the person's engaged in their care, making sure that you have an understanding of what their needs are and what their values are, and that they're engaged in the decisions. So this is probably one of the biggest shifts under the patient-centered medical home model. And the last thing that I want to touch on is the last bullet, is revitalize the joy of practice. There is a lot of talk about the triple aim not really being a triple aim, that it should be a quadruple aim. And the last aspect of that is to really focus on having providers enjoy what they do on a day-to-day basis and bringing back some of that joy of why they got into practice in the first place and avoiding the burnout. So next we're going to move into the independent certifications that are available. There are a variety of certifications that are out there, and these are organizations that do a third-party review. And I'm going to touch on a few of them, but not all of them. There are others that are out there that you may want to review as well. So accreditation programs, if you remember in the history section, I talked about in 2007, the joint principles were released, as well as the triple aim. And in response to that, the initial medical home accreditation programs were launched in 2008. And then we have ACA came out in 2010, which allowed for enhancing primary care and the actual creation of medical homes as a model that can be reimbursed. And then in 2011, the Medicare ACO models were developed, the first two versions, and all of that has been evolving out of the idea of the joint principles and the triple aim. In developing the accreditation programs, a lot of them are designed with input from multiple stakeholders. So there will be different societies involved, different action groups, stakeholders, people that are dealing with the actual accreditation standards on a day-to-day basis, people in practice, so that they can say, is this realistic or not? And probably one of the more important things is to make sure that the accreditation is aligned with meaningful use, so that if you're already attesting to meaningful use, you get some credit for that in the accreditation programs. So some of the programs that I'm going to touch on are NCQA, URAC, CARF, the Joint Commission, and the Accreditation Association for Ambulatory Healthcare. NCQA has three options that are recognized, and they don't talk about certification or accreditation. And again, you know, healthcare industry can be a jumble of acronyms and different words, and sometimes they mean the same thing. So you'll hear it talked about as either certification, recognition, or accreditation, depending on which organization that you're looking at. NCQA calls it recognition. They have the patient-centered medical home, which I'm going to go into in a little bit more detail. That is focused on primary care. Patient-centered specialty practice is anybody that's not primary care. And then patient-centered connected care is the program for workplace clinics, retail clinics, and urgent care. URAC is another certification, and they have the patient-centered medical home. CARF is primarily behavioral health home. They do not have anything on the medical model, but I threw that out there just in case anybody is in the behavioral health world. The Joint Commission is another recognizable one. This used to be JCAHO. JCAHO was primarily geared towards hospitals, and the Joint Commission has a lot to do with still hospital-based and facility-based, but they do offer a primary care medical home certification, ambulatory care, and then they also have the hospitals, and they have a behavioral health home as well. And then the Accreditation Association for Ambulatory Health Care, they have a certification and accreditation for medical home, and I'll touch on those in a later slide in a little bit more detail. So NCQA, I'm going to talk about them first because they are by far the largest accrediting organization. So recognition, if you want to look and see what the standards are, you can pull down the PCMH and the PCPS standards online. I've put the link in the presentation. There's no cost to download the standards except for the PCCC, and that's a $25 fee. So if you have a workplace or retail clinic, there is a cost, but for the others, you can pull it down and look at those without any cost. NCQA also offers a lot of training online. It covers several of the topics that are important to understand in going through the process. It's eligibility for which standards would apply, how you apply, and then what it takes to transform your practice. And then the last part is actually submitting the survey, and then if you end up getting accredited, how you maintain that and either increase it or maintain. And as I mentioned, there's broad acceptance of NCQA. Here's a map. The data is as of July 2015. This shows that there are almost 11,400 sites across the United States that are recognized. And in New Jersey, there are over 201 sites that are already recognized. This is for the patient-centered medical home, which again is the primary care aspect. The yellow dots are the patient-centered specialty practices. That has not gained as much traction, but there are sites in New Jersey. There's only less than 10 sites to have the specialty recognition. And just for a comparison point, this data is as of July 2015. In February 2014, there were just over 7,000 practices recognized. So in about 15 months, an additional 430 practices, 4,300 practices, were recognized as PCMH. So the standards. These are the titles for the standards, and this is the area focused. And what I have in this presentation is just a snapshot of the overview of the standards, all the accreditation standards that I mentioned in the overview slide. So these talk about patient-centered access. There's criteria related to team-based care, population health management, care management support, care coordination and care transitions, performance measurement, and quality improvement. And I will cover some of the aspects of the standards so that you can see that again later in the presentation. This is for the primary care standards. And this next slide shows the specialty care. So you'll see that the specialty care is similar, but not quite as comprehensive. And again, a lot of that has to do with the fact that primary care is seen as the main provider practice that is responsible for, I don't want to say owning the person, but making sure that that person's care is coordinated. The specialty practices, it's about how well they cooperate and interact with the primary care, but also there are aspects of looking at who's in their practice and how are they managing that. And so some of that with a specialty, you could be looking at severity of need within who it is that you're seeing within your practice. So the next slides are the URAC standards. And again, these are their specifics. And you'll see that the titles are similar. They're slightly different. depending on who has the listing. But again, covers a lot of the same areas. One of the issues with URAC is if you're looking for the standards, you can only download those after you've applied. So you have to pay an application fee before you can see what the standards entail for URAC. The next one is the Joint Commission. The Joint Commission actually looks at the entire organization, and the two standards that they have are either ambulatory care or primary care medical home. And on the slide, you'll see that I have those related to the NCQA levels. NCQA has up to 3 levels of recognition, and the level 1 is the lowest level. So if you were to look at the Joint Commission comparable standards, you would want to look at ambulatory care. And primary care medical home is equivalent to the highest level within NCQA, which is a level 3. The Joint Commission does an on-site survey. After your initial survey that you complete, it is unannounced. So the initial survey, you'll know when they're arriving. After that, in order to maintain your accreditation, you will not know when the surveyors will appear. You'll get notice, and then they'll be on site. They do award theirs for 3 years, and their requirements, there are more requirements to be compliant with their medical home program than NCQA. And I've added to the slide, the last bullet gives you a link that if you'd like to see their comparison of the Joint Commission standards to the NCQA standards to see which fits you better, that website link will give you the tools to look at that. And some of this is based on the Joint Commission. Their standards are as of 2011. NCQA updated theirs in 2004. The other thing that is different about the Joint Commission is not only is it an on-site survey, but they also trace the patient experience. So from that extent, they'll take a patient and follow them through the practice to see where they start to where they end and how everything is coordinated by looking at specific patients. They also will interview patients. They'll do clinical record reviews, meet with staff and leaders of your practice. They'll look at your eClinical decision support tools, how you use health information technology. They'll dive into your HR files and want to see performance improvement data. So the level of comparison is a little bit different. And in the next section, I'm going to talk about NCQA a little bit more detail so that you have some comparison. NCQA is an off-site review. And again, they don't do the patient experience with tracing it through the system, but they will look at a fair amount of documentation. And on the next slide, this is just an overview of the standards. This is for ambulatory care, which again is level 1 related to NCQA. And this will cover a whole lot more than NCQA will, like infection prevention and control. There's no comparable standards. So again, this is about your organization as a whole, and it is not just focused on patient-centered medical home. And again, the link that was in the earlier slide would give you some information about the comparisons. And again, with the Joint Commission, standards aren't available for free. You have to purchase them. The purchase price is $186 for one version, and they do give discounts if you're buying more than one copy. Titles mean again, the patient-centered medical home for the Joint Commission is looking at the same types of criteria, and it follows the joint principles. So again, you keep seeing patient-centeredness, comprehensive care, coordinated care, access to care, quality and safety. So these all resonate with those original joint principles that were issued. And again, there's a lot of information on both the Joint Commission website and NCQA's website if you want information. Those are the two organizations that seem to have the most, but the Joint Commission still doesn't have nearly as many people recognized under their model. If you remember, I said there was over 11,000 for NCQA. As of the middle of January, I went out to the Joint Commission website, and there are only 160 ambulatory care practices across the U.S. and 139 of them as of March 1st of 2015. So in almost a year, they've only added 21 practices as being patient-centered medical homes. And then the last certification I'm going to touch on is the Accreditation Association for Ambulatory Healthcare. Again, a lot of similar standards. You cannot get the standards until after you apply, and they do have an on-site review. The difference between their two levels, certification is the lower level, and accreditation is a higher level, and it's a comprehensive review of the entire organization, not just an individual practice. Those are the high-level review of some of the accreditation organizations that are available for certification. And then in the next, I'm going to talk about NCQA in a bit more detail. NCQA has a workflow that's available out on their website. First is just to make sure that you're eligible, get the standards and guidelines. They have a lot of training, and then deciding whether or not you want to pursue PCMH recognition. And then in the second part, one of the aspects that NCQA has is that if you have 3 or more practice sites that are eligible for the PCMH, you can actually get a corporate review, which limits the amount of documentation that you need to supply. You can do a multi-site, and that allows the process to go that there's a core set of standards that when you meet those, they apply to all your practice sites, and so you don't have to repeat those. There's a lot of training and software available that you can see online. And so this goes through the process of how you'd want to go. And again, this is from NCQA's website, and you can view a little bit more detail out there. And then afterwards, again, promoting your status. And one of the things that NCQA does is they will also do a press release at your request. And the other component is really to make sure that you maintain what you've put together. One of the things that from my managed care experience is that with NCQA, every time they issue the standards, the bar goes up a little bit more. So if you were to look at the 2008 standards, then they issued 2011 and 2014, you can see the incremental changes. And it's a lot easier after you get to a base level to just add on the components. But every time that they come out, it gets a little bit harder to meet the standards. And again, that has to do with continuous quality improvement. The next slide gives an overview of the 6 standards and talks a little bit about the requirements and what's involved in each area. So these I'm not going to go into a lot of detail because I want to give you an overview of sort of how the process works. And I'm talking about standards and different things. And if you haven't seen the NCQA standards, then that may not make a whole lot of sense. So patient-centered medical home. And these are actually applicable not just to PCMH, but to the other programs as well. There's a standard, and within each standard, there's multiple elements and then a factor. And within the factors, and I have an example, there are certain factors you have to pass, and that if you don't pass all 6 of them, then you can't get recognition. It doesn't matter what score you have, but there are 6 criteria that if you do not meet them, then you get an automatic fail to the extent of pass-fail within NCQA. The elements are broken down. There are patient-centered access. There are 3 elements. So within that, it's 3 subtopics, and under that, there's multiple factors. The point value adds up that there's 100 points, and based on those points, we'll determine what level of accreditation you receive. And so this gives you an idea of, just based on the point levels, if you look at the highest number of points, you've got 20 points in both performance measurement and quality improvement, care management support, population health management. That is where their areas of focus are. As things have changed, patient-centered access used to be higher points, but it's become more routine, and now NCQA, as they're increasing the standards, are really focusing on these higher level aspects of what is involved in a patient-centered medical home. So here's a sampled standard and element, and this is directly out of the NCQA. And when you get into upload documentation, they talk about the ISS tool, and this is very similar to what you would see on the ISS. So this is PCMH2, it's team-based care, and then there's element that's about continuity, which is element A, and then under that there's 4 factors. So under these 4 factors, you have to go ahead and show that you assist patients and family to select a clinician and that you document it in your records, monitor the percentage of patient visits where they've seen who they selected as their clinician or team, new patient orientation, and the 4th is that they collaborate on a written care plan for transitioning of pediatric care to adult care. And then under this, it shows you the scoring. Since there's 4 factors, this will vary under each one. So if you can say yes to 2 of them, you will get 50% of the points. So it's a 3-point value, which is up in the black box where it says element A, continuity. You would get 1.5 points towards your score. And each standard is developed, and so if you pull down the standards from NCQA, you can kind of go through this and see whether or not your practice has some of these components in place already and assess whether or not you're close to meeting some of the standards or not. And also within the standards, they will show you that an explanation. So I'm going to click back for a second to focus on factor 3, which is the new patient orientation. And in order to determine that, it gives you an explanation. It's pretty simple. Do you have an orientation about what is the medical home, what is the medical home's responsibilities, and then what do you expect out of the patient and what are they responsible for doing? And then the documentation that needs to be submitted is what is your orientation practice. So they'll be looking for written policies and procedures or some type of brochures, materials. It may be things on your website. There's a variety of documentation that you can supply to prove and provide evidence that you meet that standard. And so these are how all of the standards are set up. So this is just an example of one of them. And then I mentioned the must-pass elements. Within each element, there's a standard. So patient-centered appointment access. If you do not pass that standard, which means you have to score at least 50% points for that particular element, you don't pass. And like I said before, if you miss any one of the 6, then you cannot be accredited or recognized as a PCMH regardless of how many points you have in other areas. So the next piece is these are the recognition levels. As I mentioned, there's level 1, 2, and 3. They have the different points values. And again, the must-pass, can't emphasize that enough, that if you were to look and see whether or not your practice is in the place to go ahead and go after PCMH recognition, I would look at the must-pass elements first to see how much of a gap you have between what's in those elements and what your practice has today. And I did not go into a lot of detail on that workflow, but one of the things in transforming your practice from where it may be today to meeting PCMH requirements could take anywhere from 3 to 12 months or even longer. It depends on the level of support and the amount of resources that you have within your organization. So NCQA, after you've gone through the process, it is a 3-year recognition period. You will get a certificate which you can display within your office. You will get a survey that actually shows how your scores ranked within each of the elements. And it is specific to a practice site. It is not an organization specific, and it'll address the specific clinicians as well. You will be listed on NCQA's website so that you can go ahead and have anybody out in the community verify that you do have NCQA. And I should say the same thing is true of me. If you went out there, you can see that I actually have maintained my CCE certification. NCQA is very good about making sure that you can verify that promoted recognition is actually there. So there are a 3-level program, and if you are scored on your survey results that you received level 1 or 2, anytime within the 3-year recognition period, you can go and do what they call an add-on survey. The add-on survey will allow you to resubmit certain elements where you scored less than 75% and see if you can increase it. So you only have to resubmit those, I'm sorry, I think I said that backwards, resubmit those where you scored less than 75%. So if you scored 75 or greater, you don't have to resubmit. So you have a shorter list of documents that you need to submit. They'll score that, and if you are successful, you can bump from level 1 or 2 up to 2 or 3 without going through the entire survey process. And in that, your 3-year period would stay the same, so your 3-year period when it is up, if you've added on and you've gotten up to level 3, it'll show level 3 through the end of that 3-year period. To do renewal, it's streamlined if you reached level 2 and 3. It means that you only have to attest to certain pieces, and there may not be a full submission of documentation. And I mentioned also that NCQA will do a press release at the point that after you've received recognition. So after a very high-level view of some of the standards and what you might expect from the interview process, I want to touch on some of the benefits of recognition and why you might want to go through the benefit or go through the recognition or accreditation process. So some of this is about the commitment to the triple aim, which is, again, improving quality, improving the patient experience, and improving health outcomes. A lot of providers use this as a way of saying that with having the recognition, I've demonstrated to an independent agency that I am committed to quality and that I am focused on these aspects, whereas a provider practice that does not have that recognition can't really make that statement because it hasn't been independently reviewed. It can increase your competitiveness. The other part is that when you put a continuous quality improvement process in place, you have to have the infrastructure and resources developed in order to maintain that, and that's really critical in achieving it and maintaining your recognition. The other part that's a little bit different, and not everybody thinks this is a good thing, is you're shifting your business to a data-driven approach. Again, with having had a health plan background, we're very focused on data, not so much that you want to lose sight of the individual patient, but using data to identify areas where you may want to look more closely. And again, this is one of the aspects that I think is a little bit of a struggle. Some of the EHR systems are not the most user-friendly. The reporting and data available doesn't necessarily lend itself well to being able to do this piece, but that is one of the focuses, is moving towards using data within your practice. Another benefit is to emphasize a team model rather than it being a disconnected group of people that work together, but really focusing on how to use the best talent and leverage what each person on the team brings to the table and maximizing each person's performance. And then you can also negotiate for additional funding or start to look at value-based care, pay for performance. Additional reasons for accreditation, like I said, commitment to quality. It can improve the quality of care. Some of the demonstration programs that have been out there, pilot programs, have shown that by focusing on certain criteria, that there is an improvement in people's overall health. Some states may require that you get the accreditation, that either the insurance company requires it, an ACO may require it, your liability insurance may require it, but it also helps you manage your risk because you're focusing on quality and looking for outliers of things that may need attention. And one of the last things I'll touch on is that it can also be a recruitment tool for trying to recruit people to come to work for your practice, because it's going to be a potentially different model than they may see elsewhere. So why do insurers care? Having come from a health plan, I can tell you that a lot of insurance companies are being asked to go ahead and demonstrate outcomes. And each contract that they have can vary, which is part of the reason why practices get frustrated, because they are asked by one health plan to report a certain level of measures. A different health plan may have another set of measures. And so trying to get to some consistency, I think there's some movement within the industry of trying to get to the place where outcomes that are being requested from practices and from insurance companies are more consistent. That way you're not trying to track 20 measures for one health plan and 10 measures that are totally different for another health plan, and having differences in how those are evaluated. Insurers are also looking to shift risk, and that's what a lot of the value-based payments are about. It is going ahead and pushing down some of the ability to manage the cost and reward or penalize providers based on how they are managing care. And there is a whole spectrum of value-based payments, whether there is just upside to the provider where they can earn money as opposed to losing money. And then there's just a ton of publications that you can look at as to improvement in quality and how it affects the overall performance of each of the insurers. A lot of the insurers are doing initiatives to encourage people to move to patient-centered medical homes. Some of them are offering money and in different incentives where they may assist with accreditation costs. They may help with doing value-based payments, and it just depends on where you are. If you look at the link that is provided there, you can see some information about Horizon, who of course is the primary payer in New Jersey, and talking about their benefits of having the patient-centered medical home. ACOs. PCMH really is one of the building blocks of the ACOs. In order for the ACOs to meet their requirements, they mimic a lot of the aspects of what's in the patient-centered medical home. You can see the requirements. It's population health management, quality measures, use of HIT, patient and family engagement. These are all embedded in the patient-centered medical home. And so it makes it easier for the ACO to meet their requirements if they have primary care practices and specialty care practices that are meeting the requirements of patient-centered care. And even NCQA has an ACO accreditation, and if they have PCMH practices within their network, then they don't have to submit anything else because you've already verified that the PCMH is certified, and so all that credit kind of rolls upward. And I was at a conference in the fall, and I'm not sure how much has become public, but in South Jersey area, one of the ACOs there is, I don't know if it's gone public yet, they're going to require every single one of their network participants to be PCMH recognized. And I do not believe that they are accepting anything other than NCQA. So that will have an impact on the southern part of the state. Medicare reimbursement, again, you're hearing a lot about tying payments to quality and value. The percentages are out there. Everybody's talking about it. They issued the CMS Quality Measurement Development Plan. A draft of it was issued in mid-December. It talks about what are going to be the requirements to go ahead and submit. Most providers will move under MIPS, which is going to replace PQRS, meaningful use, and value-based payment modifier programs that are currently in place. And one of the components of this is, you've probably already seen the payment adjustments, what are the penalties and incentives. And in PCMH, if you have independent recognition, you already get the highest score for performance improvement, which is 15% of your composite score. Meaningful use is 25% of your score. And again, PCMH is aligned with meaningful use. So between those two, you can easily capture 40% of your composite score. And there will be overlap, again, with what the PCMH requirements are and what MIPS requires as well. So some of the initiatives that are here in New Jersey, I just listed these out. There's information out on the website. There have been pilot programs that have been developed, some that are still in place, some that have ended. But again, all of this is geared towards going ahead and looking at how do you get greater acceptance and people moving into the patient-centered medical home models. There's a lot of different pieces. One of the things that was just recently awarded is the CMS SIM, which is the State Innovation Model. $3 million was given to go ahead and do planning when it ties into the Healthy New Jersey 2020 plan and how they can go ahead and take the work that was done within the pilot programs within the state and move it to broader acceptance and moving it out further. And again, the other thing that you usually see is that things start in Medicare, and then it moves over into commercial, and then it moves over into employer, and it also moves into Medicaid till it pretty much becomes a piece of how health plans and insurance payers are paying different practices. So as that continues to move forward, you will see that it becomes more broadly put into place across the state. And then there's a bunch of private payer initiatives also. The different insurers all have different programs available where they can offer funds. Some are specific to a particular region, some are statewide. And I, again, have put a link on the presentation where you can go out and get more information about each of these programs. If you haven't been out to pcpcc.org, that is a great website for information. It is the Patient-Centered Primary Care Collaborative, and it has a focus on making sure that patient-centered medical homes are the model of the future. And the other big piece that they are behind is making sure that the funding is appropriate to what's being asked of all the practices. And with that, I am going to move into the question and answer session.
Okay, everyone, if you have questions, please type them in the question box so that I can present them at this time. Jennifer, right now I have one question. Who is looking at this recognition? Patients?
Who is looking at the recognition? So there's a couple people. The insurance companies are looking at it. I expect in the future what you're going to see is that it's going to become one of the minimum requirements in order to participate in the network. Patients, I'm not sure the patients are fully looking at it without the practices promoting what the understanding is. I've been in healthcare for a very long time, and I find that when I talk to my family, my personal experience is that I'll see they don't completely understand, and then when you start talking about what it means to them as a person and what they should be expecting of their doctors, it's definitely an education process. So getting patients to understand, but for practices that have put it in place and they've gotten patients to understand and engage, it's really made a difference because you're thinking about it from a whole health perspective. Again, looking at if you're in a pediatric practice and you have a child that has issues with obesity and you want them to engage in proper eating and exercise, looking at it and explaining it from a whole perspective, there's a lot more education component to this. And in doing the patient-centered medical home, I think patients will become more engaged the more it gets explained. But I'm not sure it's at that point. If that doesn't answer the question to the person, if you want to add a question, that would be fine.
Right. Or you can also reach out to Jennifer offline her contact information is attached to the presentation, which is going to be going out. Looks like you were pretty thorough, Jennifer, because I'm not seeing a lot of questions. Folks, if there are no other questions, we're going to close the webinar. I'll give it a couple more seconds. And it doesn't look like anything's coming through, so thank you everyone for attending. Jennifer, I thank you for a fantastic webinar, and everyone have a great day.
Thanks, everybody.